for that invitation, Dr. Soumya. I'll talk about orbital trauma and the role of PSIs that we now are leaning more on. But before we start, I'll just go over a practical classification. We usually call in whenever the floor is involved and the frames are intact, we call it a blow-in or a blowout fracture, which is only an internal fracture. If it involves not just the orbit but also the zygoma, and the malar area is the area of impact, commonly the tripod or a tetrapod fracture. But if it then goes medially and the impact is in the center of the face, oftentimes we have the NOE fractures, which involve the nasal, the orbit, and the ethmoidal bones. And finally, certain cases like the one that was shown earlier, where there is a complete disruption of the bony architecture of the orbit and the nose and everything, and that's a combined fracture. So we have the blow-in, the orbitozygomatic, the NOE, and the combined fractures. And how do you then, based on these fractures, decide what implant do we use to repair what? So the ideal implant is one that is stable, allows you to be able to fix it easily. It is the contour can be changed and managed based on a case-to-case basis, where the handling is convenient. It should not incite an inflammatory reaction and should be inert. And more importantly, the cost and availability, which oftentimes becomes our number one criteria when we deal with patients in our setting. So we have different classifications. We have bioresorbable, which get resorbed, and they are different from bioabsorbable or biointegrable rather. Biointegrable is where the vasculature grows into the implant and integrates the implant. Bioresorbable is when they get resorbed by the body and serves as a scaffolding over which there may be new bone formations such as PLLG or rapid sorb or even osteomesh, which are bioresorbable, which are polycaprolactone PCL materials. Permanent implants or ones that could be later on removed include titanium, and biointegrable ones are Medpore, Omnipore, the commonly ones that we use. And you can even have hybrid implants like titanium Medpore, where titanium implants have integrated biointegrable implants in them. So they, like you said, bioresorbable facilitates growth of the bone over the defect. Biointegrable integrates into the tissue, where the pore size should be at least 400 microns. These implants are a little malleable to a certain extent, not completely malleable. And finally, titanium, which is biocompatible. It is strong, non-toxic, it is resistant to corrosion. However, sometimes, and now we are seeing more of them, especially in large complicated fractures, they do cause certain amount of integration and can cause even orbital adherence syndrome, where motility becomes an issue there. And then of course there can be cases which are now being less utilized upon, where we harvest a piece of bone from another site and use that as the implant. The newer generation, of course, is the PEEK implants or polyether ether ketone. These are biocompatible, they are thermoplastic. You don't even need to make preformed holes or drills. You can directly drill through the implant into the bone and it holds that in place. They are biocompatible. The only issue, of course, being economically they are a little more expensive compared to other implants. And certain cases now, which we do, is the patient-specific implant, and I'd like to highlight the utility of these implants and the process of creating these implants through this case. This is a 42-year-old man who had a trauma a few months ago, and he had been operated primarily by a plastic surgeon, where some amount of fractures were fixed, but he still had reduced vision. He ended up with a small neurotrophic ulcer, which was treated over time. His complaints were diplopia, enophthalmos, esotropia. In generally didn't like the way he looked. He also had some resolving nerve palsies that were taking time. But on imaging, what do we see? We see here that the medial wall of the orbit is completely gone. The medial rectus is in the orbit. There's a defect in the lateral side of the bone, the lateral wall of the bone. The floor is completely bowed inwards. There is no posterior edge of the pterygoid plate. You can see that the floor is missing. So in these coronal sections, you can see the medial wall of the orbit is missing, the floor is deficient, and therefore there is this hypoglobus or enophthalmos. These are those cases where the plastic surgeon just fixes the rim but leaves the internal bony structures as it is. We call this, instead of open reduction and internal fixation, only fixations. These are those kind of surgeries. So we are left with a medial wall fracture with a medial rectus into the ethmoidal sinus, a lateral wall defect, a floor defect. Now, we won't be able to use these bioimplantable, bioresorbable or biointegrable sheets in multiple places. Now, neither can we use the regular striker or titanium plates in these unusual ways and means. So what we do is we then plan a patient-specific implant where in a stepwise manner we get CT scan images. These CT scan, depending on your designer, will ask you to get either 0.5 mm cuts or 1 mm cuts. The DICOM images are imported. What they use is they use the normal contralateral side as the template, and that is superimposed over the affected site. And then the difference is assessed. What do you need to do to make the affected site look like a normal side based on your structure and volumetric analysis, and then a template is created. So if you see here, this yellow outline is the normal side of the template that is being mirrored over here. Now if you see here at different points, now suddenly you start seeing this different color. This is the proposed implant that can be used to make this side mirror this side. If you see the medial wall, this medial wall is somewhere over here, whereas this medial wall is here, and to create a mirror of this, we'd have to place this implant and also address the lateral wall defect over there. So now you can see how the implant is being fashioned, and that is how the implant would be placed so that we can match the structure and the volume of the normal side. Now this is on the coronal sides. Again, you can see how this is the implant that we will need, covering the medial wall, the floor and the lateral wall. And based on certain refinements, especially as we go posterior, we'll need that. You have to possibly have multiple calls or discussions. Now in the floor also, using the same yellow line as the template that is being mirrored, we would have to use this implant because the existing floor is way down. So this implant would land up here being there. So we will of course do a volumetric analysis and finally trim and shape and customize the implant, and then fix the created implant in the orbit, and then try to see the volumetric analysis. So if you see, the previous volume on the orbit was 32 cubic centimeters, whereas the normal side is 26. So after placing the implant, if you were to do a volumetric analysis, they more or less match. But the implant that the engineers come up with is something like this, and you can imagine how difficult it is going to be to place an implant like this. So then you have to work with them. This was the first model they gave us, and then we had to tell them, why don't you come and put this, because we won't be able to put it. Then we work with them, and we managed to make it into two integrated pieces that club in together. So this is the 3D implant that they create normally. I used to collect them earlier, but now we have so many that it's no longer of value, and they look nice in the office though. So these are the titanium implants that they make, and they send it to you. And of course surgery is as normal as you would expect. Post-operative imaging is key, because this is where the proof of the pudding is. Now you can see how the medial wall is now newly created. The floor is also created. The lateral wall defect is created, is been addressed, and the floor is also going there. These are 3D reconstructive images. Dr. Shruti will attest how Dr. Gangadhar Sundar always insists, more than the surgery, it's the post-op imaging that matters, and you have to do it to know where the implant has been placed. And there was a little motility deficit. There was a squint surgery was required where the MR was released a little bit, and the primary position was addressed because the patient still had a lateral rectus palsy. And this is how the patient was 2 months post-surgery. You can see that there is still some superior sulcus hollowing, but the eye is maintained in primary position. There is opening of the eyeball. There is enophthalmos, and motility have significantly been addressed. The PSI is definitely a breakthrough. It is, you can customize these scenarios in unusual cases where you will not get an off the counter implant that you can place in. It can give you satisfactory outcomes, and at the most, and the most important part being that these are actually very economical. They're not out of reach, and patients should not have to burn a big hole in their pocket to get use PSIs in their cases. So with that, thank you.
Thank you, Dr. Akshay, for that detailed talk on the orbital implants. It's always a pleasure to watch you speak, sir.
Thank